Welcome to the Voices That Propel Us, stories of justice, action, and community, a space where justice meets action and community voices rise. Each episode, we bring you stories from the front lines, changemakers, disruptors, and everyday heroes who are building a more just, equitable, and liberated world. This is more than a podcast. It's a call to listen, learn, and move together. You were just listening to music from the incredibly talented Stephen Kong. You can find him on Spotify and Bandcamp. Today we have with us Dr. Eugene Manley Jr. Dr. Eugene Manley Jr. is a biomedical engineer, cancer scientist, nonprofit founder, and health equity advocate working at the intersection of science, community, and justice. He is the founder and CEO of the SCHEQ Foundation, STEMM Cancer Health Equity, where he builds plain language tools and community-centered programs that help underserved populations navigate the cancer care continuum and helps expand who gets access to STEM pathways and leadership. Eugene's work is deeply personal. Raised as a first-generation scholar in Detroit, he watched his mother struggle to understand medical notes and test results that were never written for her. More recently, after reconstructive foot surgery, he experienced bias firsthand when pain and mobility were misrepresented in his medical record and the support he needed was put at risk. Through SCHEQ, he creates health literacy infographics, convenes an annual lung cancer solution summit, and equips people with practical questions and strategies to advocate for dignity, accountability, and better outcomes. Okay, well, hello. Thank you so much for joining me today. How are you doing today?
I'm good. How are you? It's a pleasure to be here.
Yeah, no, I'm doing well. Thank you for asking. I think you do such wonderful work, and I'm really excited to explore your journey and, the story and learn more about, the wonderful things that you do for others. So just to start off with, when people hear biomedical engineer or cancer scientist, they may not immediately think of justice or community. So how do you define the work that you do?
Well, biomedical engineering is such a broad field. It's, instrumentation, it's biomechanics, it's tissue engineering. And then the cancer biology is, on one hand, it's cell culture, it's animal models, it's clinical trials. But I took that training and then became a nonprofit, worked in nonprofit space and then founded my own nonprofit. And originally I was not so much focus on social change and justice. It just happened that I saw so many disparities that my family faced. And then other patients saw that they didn't have information that others received. And they started asking me to develop content and programming around it. So I evolved to do more of this work for underserved communities. And so that's sort of how it sort of grew. But I've seen this stuff my whole life, but finally it just became conceptualized for me.
Okay, no, thank you so much for sharing that. And, I love to learn more about your personal background. So you've shared that your journey into health equity is deeply personal, which, I really appreciate. And so can you take us back to Detroit and talk about how watching your mother navigate the medical system helped to shape you?
That was challenging because, I grew up in Detroit, first gen poor. I was the youngest.
Okay.
And I routinely saw how my mother was treated in healthcare system and doctor interactions and hospital interactions. And, often, she'd be ignored, dismissed, sometimes ridiculed. They would just, she'd be in a hospital overnight and they wouldn't leave her lights on. And she had this fear of darkness. And they would just do silly stuff. And it was a lot of her life was dealt with that stuff. And so just seeing how she navigated it, it made me understand that not all patients understand medical information, which is no surprise, but I'm a PhD in sciences. I can read my chart, but most people cannot. And so, doctors need to be able to not just say, oh, what's on page 5, explain it to the patient, see if they have questions, make sure they internalize before you send them off, because then they're going to get home and then try to read this and then they're going to get frustrated because of the jargon. Okay. And so it sort of laid a foundation for me as to really not everyone has information and access, and we shouldn't assume
Mhm.
that everyone has information and access.
No, thank you for sharing that. And I know you shared this a little bit before, but I'd love to further explore this with you. So, was there a specific moment when you realized that this isn't just a science problem, but it's also like a justice problem? Because, I think it's so important. So I also studied sociology at UC Berkeley and learned about like health equities and stuff. But where was that moment when you made that click of like, this is not just like a health issue, it's a larger like social issue?
Well, growing up, when you see how your family's treated, you kind of
Hmm.
know it's there, but you don't. It's not just that you don't think about it. There's so many other things you're dealing with that
Yeah.
and if you let all the stuff that happens bother you, you will really be overly stressed.
Uh-huh.
But it became much more clear as I got older. I just saw how she still wasn't able to engage care, wasn't able to get questions answered, was routinely dismissed. As I transitioned to working for lung cancer nonprofits,
Okay.
Black patients and community members started reaching out to ask me to develop programming and
Mhm.
events about lung cancer disparities, lung cancer inequities.
Okay.
And ironically, my PhD was in lung cancer, but
Okay.
when I started my PhD, it wasn't so much that disparities weren't around, but we only
Right.
had chemotherapy and radiation at that time. We didn't get biomarker start developing biomarkers until 2023. So there just wasn't a space to think about lung cancer disparities. But then as I progress and just see we have all these clinical trials that don't have representation. We
Right.
have patients that aren't offered biomarker testing. We have these patients that don't get the same resources or get told about, well, my doctor told me this. Well, the Black
Mhm.
patients don't hear any of this. So I
Right.
said, what can I do to start trying to break down these information silos and trying to amplify and uplift and empower these communities?
Yeah, no, thank you for bringing that up. And I think you bring up a really important point. I feel like because I do a lot of activism too, specifically working with communities of color, and I feel like sometimes people are saying, "Oh, don't play the race card," or "Why do you keep talking about race?" But it just race is so deeply, I think, is in our society, and race like really does matter. So, have you ever brought those like observations up and like had like any pushback from people?
Yes, when you're in some spaces that are science heavy,
Hmm.
you don't get to have robust discussions because
Yeah.
a lot of times, either you're doing in a training program or you're a resident or fellow, and you still need to get to your next stage of your career. So you can see the disparities, but if you speak up too early, then you're not going to get letters of recommendation. You're going to
Right.
get marked down, and then you may see things happening with patients, and you if you speak up, then you're going to have a target on your back, and often when you're progressing through these spaces, you may be the
Mhm.
only Black person in a space or on a floor. And then you're like, okay, am I going to make this harder? It's not that you don't want to advocate,
Right.
but then
Right.
you have to really think where you are, how long you're going to be there, and where you're going,
Yeah.
um, to determine if you can effectively speak. And you really only can start
Hmm.
advocating and impacting the way you need to once you are in a position to drive the change. So, in
Yeah.
essence, either leading your own organization or being the head of a system, but that still depends on also what the organizational leadership allows you to do, if that makes sense. So, like, I run my own
Right.
nonprofit, so I can do the focus work for underserved communities, but a lot of times you're still within
Hmm.
systems that tend to be slow to change and they're very resistant to change. And so
Yeah.
that's a hard thing to navigate. But and a lot of times people might just get frustrated and finally leave a place because well,
Hmm.
if I'm not going to grow or be able to impact what I need to, then I don't need to be here. And so it's just a
Yeah.
question of how many times will you jump, not
Yeah.
in a bad, but like how many times do you need to jump to find a place that might give you some
Right.
room to do the work you need for your community?
No, thank you for sharing that. And yeah, actually, I'd love to talk more about your foundation. So, what gap were you seeing that ultimately led you to create the SCHEQ Foundation?
So there were actually three
Okay.
sort of emergent themes my whole life. I was a
Hmm.
first gen scholar and I was always in the hospital until I was 10. And so I had an appreciation for medicine, but I
Okay.
recognized that very few Black inner city kids get exposed to science at early ages.
Uh-huh.
And so, and typically if you don't reach kids around by third grade, then they're going to find video games, sports,
Right.
other stuff. And so I saw that, as I navigated undergrad, grad, postdoc, and I said, well, we need to start trying to get kids exposed to these things at early ages,
Right.
encouraging them, letting them know that there are people that look like them in these spaces, and trying to
Yeah.
teach them how to get into degrees, but also not just getting into college, but
Mm-hmm.
how do you navigate that space? How do you navigate grad school? How do you
Yeah.
make the next step? Because when you're first gen, there's so many things you don't know going in. And so how do you find agency and community, and know who and what to say and who to talk to? And so trying to put them in a position that they can get through these spaces and get in professional, hopefully biomedical careers. So then on the backside, they can start doing work and research that impacts these underserved communities that often aren't included in research. And
Yeah.
so that ties into the third area, which is this whole health equity and disparities. And like I
Okay.
said, I talked about my mom not having information access and a lot of the underserved patients not knowing stuff. So we work to create infographics to break down medical information and cancer information. And then we do webinars on lung cancer, trying to help educate and empower people to advocate for care they're entitled to.
Okay. Okay. Thank you for sharing that. And so SCHEQ focuses on plain language tools. So why do you think that language is why language is so powerful and often overlooked, like in terms of inequity in healthcare?
Well, if we think about health literacy, across the board, our health literacy is low. And health literacy is the
Mm.
ability to read, understand, interpret medical information. But, typically if you're poor or Black and other combinations of things, the more
Uh-huh.
disparities you have, the worse your literacy. But the
Yeah.
problem is when you aren't health literate, then you don't know what questions to ask. You
Hmm.
don't know how to advocate. You don't understand how, you can get second opinions. And sometimes, depending on where you come from, sometimes in Asian cultures,
Yeah.
they are taught not to question the doctors. So
Right. Right.
and so it's, trying to put people in a position of you are in control of your health care. You are entitled to ask questions because a lot of times there's, so many minority patients are dismissed in healthcare interactions, or
Yeah.
they're told their symptoms aren't real, or we're told we don't feel pain. And so you try to make sure people know that you are within your right to get care and to get second opinions. And
Yeah.
you should go to your doctors, not wait for your doctor to give you stuff. Go in with questions about, well, what test is this? What does this result mean?
Yeah.
What is this disease? So you can go in and ask questions, and you should be able to get those answered.
Yeah, no, thank you for sharing that. So, you often talk about who gets to build the system. So why is access to STEM pathways an upstream justice issue?
Well, this is important because we all, a lot of times we talk about we want more patients in trials and in research. But then
Uh-huh.
if you look at often the clinical trial teams, they're at major medical centers, which often aren't
Yeah.
diverse. They're at CROs that often aren't diverse. And then they'll have clinical trial coordinators that typically are not from the underserved community or the community they
Mhm.
serve. And then the people go in and say, "Look, who are you? We've never seen you before. We don't know you. We don't trust you. You don't
Right.
spend the time building relationships with the community. So why should we engage?" So my whole philosophy is if you don't have a pipeline or a workforce that goes in with the
Yeah.
skills
Right.
from these underserved communities who have that cultural competency and understand, lived experience and how to bring that nuance and care, then you can never really move the needle for these underserved communities. So that's why
Yeah.
I say getting a diverse workforce, so starting them early age is getting them in STEM, helping them
Yeah.
navigate those degrees and degree transition and getting them in the workforce is the key to helping to mitigate some of these barriers and challenges that we see later on.
No, I really love that. And I think it's so like crucial, just being able to like have those different pathways, for folks because, I don't know too much how it is now, but I remember learning in my classes how like, communities of color, like certain folks were like pushed towards like a certain career where, maybe discouraged from like STEM fields. But, I think it's great to like be able to show young people at that age, just like STEM and, helping them to like build pathways for successful careers. So what do you think that, how do you feel that addressing STEM with young children at a young age, like benefits them? And, what do you think happens when you don't like show them like these kind of skills at a young age?
This is a good question. What I
Hmm.
will say is, I have a friend that runs a sort of a nonprofit called Saginaw STEM, and
Hmm.
he does a lot of hands-on demos with the kids once a month. And they do solar cars, they do cardiovascular stuff. So, and I just told him, I said, the biggest key, if you get the kids early,
Hmm.
you can spark an interest in them, or at least an interest in those that are more likely or might have an interest in science. And if you get them early, they're more likely to stay with it. And he
Okay.
kind of concurred. He said the kids that start at his program, like around third, fourth grade, they stay and are well engaged in high school. But the later ages they come into the program, then they're already
Mhm.
distracted by sports, and then they aren't really engaged, and they kind of may not. They may be there because their parents put them there to get them out the house.
Yeah.
So it kind of confirmed sort of my belief is that if the kids can hear and see people like them at early ages,
Uh-huh.
they're likely to feel they can go into space, because most of the time, at least in the US, when you're poor and underserved, you're already told what you can't do and what you can't amount to. And my belief is, well, I believe to tell you what you can do. And so
I
part of the
love that.
things that I do is, because I don't have bandwidth yet to build science demos, but we
Yeah.
do try to do daily posts for Black History Month and Hispanic Heritage Month, so people can go and see these profiles of different people from the diaspora that have done things in STEM. And what I do is I make sure that we don't just highlight MDs or PhDs. I want you to see the whole spectrum of people that have done stuff, some that have not had degrees, and that, the whole collective, we have done things. And so you can be inspired.
Yeah, no, thank you for sharing that. And, I'd love to just hear from you. Are there any stories that you can share of a young person or community member whose trajectory shifted because someone made STEM feel possible or accessible to them?
I can talk about me.
Okay, yeah, I'd love to hear. I'd love to hear about that.
Like, I was always interested in science, and well,
Okay.
and I don't know if my father was a chronic smoker, and
Okay.
and he was out of the house after I was here, but I always knew where he was. But I'm pretty sure that early exposure to him made me probably help trigger my chronic asthma and my allergies. And so I was in
Okay.
the hospital 20 to 30 times a year from when I was 5 till I was about 10. So, like, I never got to swim, but I was always in the hospital. So I got an appreciation
Okay.
for medicine. But I never knew I was going to do a research career until I think maybe my science department head in 11th, 10th or 11th grade
Yeah.
kind of saw I had an aptitude for science. And
Okay.
so she helped me apply for my very first lab research job. And so it
Mhm.
was at that time, I want to say it was Carmano's Can. It was Michigan Cancer Foundation, which is now called the Carmano's Cancer Institute. So
Okay.
I applied for that job in 11th grade and got that after the summer of 11th grade. And
Wow.
then, I'm one of the people, if you show me or give me an inkling or a push to where something is, then
Yeah.
I can pretty much go on autopilot. So after that, and I learned that there are research programs that
Yeah.
you can apply to and get this experience, then I basically did research every summer. Even though my undergrad was in mechanical engineering, every single summer
Yeah.
I was doing some kind of medical research. And I really appreciate that science department head, because she also knew I had ADHD and I was never good at taking orders from people. And
Hmm.
so she told me, Gene, you are going to have the road less traveled. It's going to be painful and hard, but you are going to do something great, but you're just going to do it at your own pace and own time, because that's just how you are. You'll get to where you need to be. It's just
Yeah.
you just are different and unique, and not in a bad way. You were just, she saw my ADHD before I saw my ADHD, because I didn't even
Okay.
get that diagnosed until late in grad school.
Okay. No, that's such a beautiful story that you have. And because of your own personal experiences, do you feel like you're able to like help motivate like another young person if you like see that potential of them, but they don't see that in themselves and might think that they don't have the skill set or because I think even for myself too, I think when I think of STEM or mathematics, like, I'm just like, ooh, that just sounds scary. But I feel like when you break it down, it feels like a lot more manageable. But yeah, do you feel like you're able to like also inspire like young people because of your own story?
Yes, because I grew up, like I said, I was the first one in my family to go to
Yeah.
college. So I went from the lens of being the only one. So I had to learn
Okay.
everything on the fly. But because
Yeah.
I was always the outsider because of my ADHD and people, why are you so weird? And I didn't know why I was
Uh-huh.
weird, but it's not that I'm weird, I'm just ADHD. But
Yeah.
it made me have a better understanding of how to read people,
That's
how to
beautiful.
accept
Hmm.
people, especially, and I think when you get to neurodivergence, it gets tricky. Like we
Yeah.
have some very unique characteristics, but typically we can empathize. It's
Okay.
just a question of how much empathy can we have at a time. So
Hmm.
so I know my attention span will wander. Sometimes I'll be there now I'm out. So
Okay.
but I tend to there's a there used it's a trait I forgot what it's called, but because I'm
Uh-huh.
so used to being on the outside, I'm able to sense when someone is in a group or in a setting
Mm.
and they're isolated. And I've just always managed to go to that person. I don't know, I
Yeah.
forgot what the term is called, but that's just been something I've always done.
Yeah.
And that's sort of been a recurrent theme through my life. So I've been able to sort of see who's the person that needs the help. And then
Hmm.
I tend to know who to avoid because I don't like to deal with arrogant, obnoxious,
Yeah.
unruly. I just and that helped me get out of Detroit because I learned who to keep away from me.
No, that's really beautiful. And so when you say that health equity has to show up at the bedside and in the chart, what does that look like in real terms?
Okay, so this came from actually my own experience
Okay.
in hospital system. So
Hmm.
I slipped and fell and fractured my ankle at the
Okay.
end of December of 2024. And
Okay.
so I was in a boot for like the first 6 weeks of last year.
Yeah.
And in that time, my mother had died, and then I had to go to West Virginia on
Okay.
one foot. But then I had reconstructive surgery of my foot in March.
Okay.
Now, I have a biomechanics background and did a lot of years of jujitsu, and I've
Okay.
torn an ACL. So I know my biomechanics. So I was not
Yeah.
worried about the surgery. I knew it was going to be a lot of pain. And I had a robust discussion with the surgeon. So the
Hmm.
surgeon and I had made a comprehensive plan. I said, just can we please put me in skilled nursing for the first 2 to 3 weeks because I live alone. I
Right.
don't have any family out here. And when I was in the splint the first week before I got in the boot, I could not really do anything when I had two
Okay.
crutches and a foot that I couldn't put weight. So now I'm going to
Okay.
have surgery that's supposed to keep me non-weight bearing for 6 weeks. And
Yeah.
it's so ungodly painful, either using a walker or a scooter. So I could not do anything. And
Yeah.
so we did the surgery. We got out of surgery like that Thursday evening. And he said, okay, it's so late. We're not going to get your skilled nursing placement on Friday. So we'll do it on Monday. And he just asked PT to come and do an
Mhm.
assessment for skilled nursing. But the person that came in had such horrible bedside manner, was rude, dismissive, just completely
Mhm.
disregarded everything I said. And then I found out that they lied in my medical chart and said I
Oh
had no
no.
pain and could
Yeah.
ambulate. And then this led to a whole cascade of things from the rest of the hospital. So they
Mhm.
also tried to give me an early discharge notice less than 36 hours after the procedure, and I had no follow up with the surgeon yet.
Okay.
The hospitalist tried to ask me about my ability to pay, and at this point, I'm frustrated because I
Yeah.
can clearly see that it's part bias, part racism, and I'm like,
Yeah.
they are not listening. And I
Yeah.
was so exhausted, like I really had no voice. I'm on these painkillers. I can't really speak. And then she wrote us up, asked Pace about ability pay, and he cried. I'm like, you missed the whole other
Oh
thing about you
wow.
not
Wow.
listening. The fourth day, like they had another patient in the other bed. The staff hit myself like 3 or 4 times in a 30 minute. That's the only time I really yelled at them. And then
Yeah.
they wrote in the chart combative patient or something. And then even on and then they were saying, well, if you
Wow.
go home, we'll get you home aid services, which was a lie
Uh-huh.
because they had already wrote in the chart, which I didn't realize till 4.5 weeks later, well,
Yeah.
3.5 weeks later, that they said patient has no pain and can ambulate. So because they wrote that,
Hmm.
the surgeon couldn't get me in skilled nursing because it was denied by insurance. And
Okay.
insurance asked, well, why didn't you not appeal sooner? But PT ignored the surgeon for 5 days until he finally complained higher up in the hospital. So then they finally, and oh, but we're not changing because,
Wow.
he has no pain. And I was like, how can you write that in the chart when this procedure literally is 6 weeks non weight bearing and you're trying
Yeah.
to Oh, it was pretty ugly and harrowing. And then I just think of all the stuff my mom dealt with and how she was ignored. So basically, what people write in the chart directly can influence how your care is or isn't delivered. So because
Yeah.
of the fabrications, insurance saw one thing and I said, well, then I can't get the follow-on care. So I ended up being stuck at home
Yeah.
alone 3 weeks before a friend showed up because I didn't expect to be home. So I didn't plan to be
Hmm.
home. But it made me realize that if you did this to me, someone who knows how to
Yeah.
advocate,
Right.
then what are you doing to all these other poor and underserved and Medicaid patients that don't know how to advocate,
Yeah.
who don't know how to read medical records, and then you're pushing them out, and then they come back later with readmissions
Mhm.
or injuries and stuff, and they don't even know why because they can't go in depth and read the records like I can.
Yeah, no, I think you bring up a really important point too. So I think when you look at it more of a micro level, it's like, oh yeah, there's a negative, experience that you have, and I'm so sorry that you had to experience that. But I feel like when you go further back, you could start to realize, like, no, actually, this is a systemic issue, though, and people do have
Yes.
biases and assumptions, even though it might be like unintentional or they're not aware about it. But I think yeah, like I was talking before, like, yeah, these different identities that we carry with us, they do impact us. And like I think it's harmful to say that there are no like impacts of our identities. Like everyone's treated the same. It's like, no, it's people
Oh,
definitely have
yes.
their
Oh,
biases.
of course. And it's not in healthcare at all. I mean,
Yeah.
the whole ideal that we started, history of gynecology with Black women that had
Hmm.
no pain, no anesthetics or anything. And so
Yeah.
this is not a new thing, but a lot of people believe this stuff doesn't happen. But I've
Right.
saw this stuff happen to my mom, and it just happened to me. The only difference is
Yeah.
I know how to advocate and read records. But
Hmm.
even that, my whole big thing is my degree still didn't protect me from
Yeah.
medical system. So the people charting have way more power over you and your outcomes than people realize. So I
Yeah.
try to make sure that everyone understands when you go into a hospital setting, make sure you have a medical proxy that can go in and read your records in real time.
Yeah.
Make sure that you know who to complain to when you have issues. Make sure to write
Hmm.
certified letters. Make sure to file with the certifying agencies and make sure to talk to patient advocacy if they do or don't answer. But I made a whole series about how to navigate care and protect yourself because that showed
Hmm.
me that even though me and the surgeon were in alignment, they iced him out of the records because he didn't have direct admitting privileges, which
Right.
means I prepared what I thought was correct and it still was not enough.
Yeah, no, I'd love to hear more about that though. So, what are some practical questions or strategies that you encourage patients and families to use to advocate for dignity and accuracy in their care? Because I think it's great that you were aware of it for yourself, but what can you offer to other people who might be struggling with this too?
So, you can think of this in two terms. If you think of just general medical appointments, you
Mm-hmm.
should always go into your appointment, have
Uh-huh.
like 2 to 4 questions for your doctor. Or
Mm-hmm.
if you get a test result and you go back, well, what does this test does? What does this test? What does it mean?
Right.
What do I need to follow up? And like sometimes they do metabolic panels and you'll see the numbers like as
Mm-hmm.
in this range. You would think you're
Okay.
right to ask the doctor what these numbers mean.
Uh-huh.
If you have a cancer diagnosis, you think you're right to ask for
Yeah.
second opinions. So many
Yeah.
cancer patients don't realize they can get second opinions or they're afraid to be problematic. Say, the hardest
Right.
thing for someone to deal with is a cancer diagnosis because your
Okay.
whole life flips upside down. And you can't ever really understand the experience someone with cancer diagnosis goes through because they don't know what stage, they don't know if it's
Mm-hmm.
treatable, if they're going to be on chemo forever. It's the most harrowing thing to do. But and then
Yeah.
if you translate this to surgeries, I think my stuff is specifically applicable for surgeries. Make
Okay.
sure you have that medical proxy. Make sure you understand the procedure. Make sure you
Mm-hmm.
understand what you're supposed to do post surgery. Make sure you have people lined up that can help you if possible. Make sure
Yeah.
you know who to contact at that hospital. Make sure you know the patient advocate at that hospital. If
Okay.
you find things awry, make sure you know the chief nursing officer. So have things prepared and questions and make sure you have any question answered before you go into procedure. And then if you are after surgery and you're on kind of opioids or whatever,
Mm-hmm.
do not let them talk to you. Make them talk to your medical proxy because you are
Okay.
not lucid, because they will try to use it. Like, there's a thing
Right.
called AO3, alert, oriented, and aware.
Oh,
They
okay.
use that on me to say I was lucid. I knew I was not lucid, but
Wow.
because I knew the day and time and where I was, they said alert. So they didn't call
Mhm.
my medical proxy. Now, I know how my brain functions. I was clearly not alert because they use that as a base. Oh,
Yeah.
he said yes and he affirmed. I'm like,
Yeah.
I see this game. So, yes.
Yeah. No, that's horrible how they take advantage of folks because this like has very like real life consequences for people. I would even say like life or death consequences for people. And like I feel like this isn't something that they should take lightly though. And yeah, I'm really
It's,
grateful that you're bringing light to this subject though.
yep, it shouldn't. And, and it can be life or death because, like, I got home and they wrote this, oh, he can walk and go to the store. I'm like, I can't. And I failed
Yeah.
trying to go get prescriptions the next day. And it's a
Okay.
miracle I didn't set my recovery back. It's just a
Right. Right.
miracle. But
Yeah.
it makes it so important. It reinforces why the work I do is so important. It's
Hmm.
not so that I can be the only one to advocate, but if I don't help and empower others, I can't necessarily wait on other people to do it.
Okay. Okay. No, thank you for sharing that. So, SCHEQ's tools are community centered and not top down, which I really love. So, why is that distinction so important?
I think, a lot of times people want to develop programs or interventions, but then
Hmm.
the people in the room don't reflect what the community needs are. And so whenever that happens, then
Hmm.
you have only one lens looking at a situation, and then that is never a good spot to be in. It's like, we're going to
Yeah.
run a trial in this community, but we have no one from this community. We don't know anyone in this community. We don't know what their needs are. We don't know if they need transport. We don't know how
Hmm.
they're going to get here. And so it was important to me that we put in place our patient advisory board,
Okay.
which we when we get infographics created, we run them by our patient advisory board to make sure they are legible, understandable, and they don't convey anything that they don't want to. And then we send them to our medical advisory board to confirm the scientific accuracy and validity.
Okay.
And only once those two passes are met, then do they get posted on the website.
Okay. Okay. That's beautiful. Thank you for sharing that. And what does practical hope look like for you, especially when you feel like progress is going slow?
Practical hope is it's one thing. For as much as things go wrong, we know we
Hmm.
are getting better at diagnosing disease. We're getting better at developing therapies.
Yeah.
And so, and we're at least getting better at teaching people how to advocate. We were,
Wow.
for a while, we didn't have a lot of patient training programs. So there are more programs coming online that
Hmm.
are teaching people how to advocate for care. And so I think that that is something that's very promising.
Yeah, no, thank you for sharing that. And, something that I really love about this podcast, like I've been able to have like amazing conversations with people in so many different fields, including yourself, like doing justice work, trying to really empower our communities. But for a lot of people, like including myself, like justice work can feel heavy. And, sometimes I do feel that like loss of hope as well. So, I'd love to hear your thoughts on this. So, for those doing justice oriented work who feel burnout or disillusioned, um, what has helped you to keep going?
So here's the thing. If you are so, and this is my take, not a universal take, but
Hmm.
if you are so focused on justice that you don't take care of your own mindfulness and mental
Yeah,
health,
no,
you
totally.
will burn out. The problems will still be there whether you are there or not. So don't
Yeah,
become so absorbed that you can't breathe and live your own life. Don't let the
yeah,
stress overburden you, because the stress is always going to be there, but
yeah.
try to do things at scale and scope, which I know is hard because
Hmm.
when you're trying to do social justice, you're trying to overcome everything. But my philosophy on health equity is there's many problems to tackle,
Right.
but fix one part or one piece that you can do. And
Hmm.
then once you get that area done, then you go to the next piece. Don't try to necessarily tackle it all, which so there's some overlap between health equity and social justice, but
Hmm.
and there's some distinction, but at least health, you can
Right.
do it in pieces.
Yeah. Is that something that's helped you go to? Is that like something that you've had to learn to lean into, like with your experience?
Yes, a lot of
Okay.
I don't so much do as much mindfulness, but I have
Hmm.
my ADHD, so
Okay.
sometimes I have to just go for a walk. Or
Yeah.
often for me, my relaxation is I listen to music,
Hmm.
techno music. But
I love that.
I know it. But ADHD, we have something. So it's
Yeah.
weird. Only ADHD people can listen, can focus in loud music background. It's just we just
Yeah.
need, for us, the noise in the
Yeah.
music is sort of like our white noise. It's the filter because otherwise
Hmm.
we would be overstimulated. So I know it sounds crazy. So that's my way. And then if I had time, I would travel. I would love to travel, but right now I just haven't really been feasible. But yeah, but my thing is
Yeah.
music. Walking. I've learned that actually I get my best thoughts, which is sad because I'm walking. Usually my
Hmm.
best thoughts are walking and rambling my mouth. And I said, why do I carry a recorder when I do this? Because then I miss some of
Yeah.
my best
Right.
ideas.
No, that's funny that you say that. Actually, that's the reason why I started this podcast too, because I love just naturally talking with people and getting deep into their stories and just like asking deeper questions. And I think what made me think of this is because actually sometimes I talk to my friends and we get really deep with like a topic and they're like, dang, Denise, we should have been recording this. I was
Yeah.
like, I was like, why don't I do this? And the podcast, this is what I'm doing. We're like having these amazing conversations with people and then being able to put it out into the world. But yeah,
Yep,
I
this
totally
is
get you
great.
with that too. Yeah.
But we all have to find like something that helps us decompress. You just have
Yeah.
to find
No,
something. You can't
totally, totally.
go all out because that's just gonna, really just it's not gonna be good for your health long term.
Yeah. No, that's what actually I've been learning a lot too, like just like resting is a radical active resistance in itself because I think like oppression teaches us to like keep going, like burnout
Yep.
and all this. So it's really like for us to take care of ourselves and encourage other people to take care of themselves too. Like that is a way of like social change as well in itself.
Yes. Yes.
Yeah, yeah. So, what is one thing that you wish every healthcare provider understood about patients from marginalized communities?
I wish they would understand that these patients have lives and experiences
Hmm.
and issues that often go beyond what you just see in the clinic, and that you
Yeah.
really should treat them with respect and dignity. Like, think of it
Hmm.
like this: if you treated these patients like you would treat your family in a healthcare setting, we would have much less issues, many less issues.
Uh-huh.
Did I use the right tense?
I love that. Yeah, no, I really love that. And something so another thing that I do want to do with this podcast is like to show people that there are like tangible ways and through these discussions I want people to walk away feeling empowered to make differences in their own lives. So if listeners want to move from awareness to action, what's one concrete step that they can take today, whether in healthcare, education, or in their own communities?
Well, what you want to do, you have to understand what is the problem you're trying to solve.
Okay.
And that could be a big problem. And then, like I said, put it in a piece that you maybe alone or with a group have the ability to tackle, and then sort of put a time frame on
Hmm.
which you want to try to tackle it. You don't have to hit it, but sometimes if you put a time frame or something, then it sort of helps you keep on task. And so that's my way. Just you sort of, what are you trying to address? Why is it important?
Hmm.
What are the barriers and challenges, and how can you address it? And then maybe you have three ways you're going to address it, and maybe go for one of them so you don't get overwhelmed. But you could do all three. But
Yeah. No, I think that's really cool. And something that you were talking about earlier is just like what kind of questions that you can ask your doctor, but like I feel like people might even feel intimidated. I think for myself personally too, I've had my challenges with healthcare, but I think it does take a lot of courage. So what would you say to folks to like help give them that courage and feel empowered to ask the questions that they need to ask to advocate for themselves?
this is, like I said, sometimes this is hard for people to learn because sometimes, the doctors are treated as the end all be all. And
Right.
sometimes the doctors are rude. But at the end of the day,
Yeah.
it is still your life and your health. And you have to go in there with the lens that this is about me. and what I need as far as my outcome. And so if you go in there with a position of what do you want and need, and then keep that in the back of your head, then you can frame that with your questions. You can say, okay, what does this result mean? Or I need this test. And then if you come up with a rationale for why, you should be able to get it. But that is hard for a lot of people to learn and speak up. Some people are inherently reserved and they're not, what's the word I want to use? They aren't, I wouldn't even call it rocking the boat. Sometimes they're not good at question and authority is not exactly determined, but you know what
I know what you mean. Yeah, no, actually, because like a personal experience. So as I mentioned, I've had my own frustrations, unfortunately, figuring out this like health system, but it's just like I felt like I kept getting dismissed by doctors. And I remember like friends would tell me, but Denise, the squeaky wheel gets the oil or whatever that saying is, but it makes me feel uncomfortable. But I'm like, I think it's horrible to know that like these professionals who are supposed to take care of us like will dismiss us because I think I'm a person that you just described. I can be pretty reserved, but like I remember one time I was just like going through a lot and like I just want to show professionalism, so I just asked something. They're like, "Oh, I'm sorry, I can't do anything for you," and at that moment I was just so frustrated of being dismissed, time after time, and I just started crying. And then they're like, "Oh, no, let me see. I could see if I could do something for you." But it's like it shouldn't have to get to that point for people to get the care that they need, though.
You in Canada right now?
No, California.
California. Oh, you're in California. Because I was gonna talk about the difference in sort of healthcare in the U.S. and Canada.
I don't know the differences. Yeah, if you could explain that.
So some of this, I know this wasn't even a topic for the podcast. So when we look at Black and immigrant communities in Canada, they in a census count them all as Black, but they don't disaggregate the data.
Okay.
When they do public health or community health assessments, but then all the Asian subgroups are mainly separated. So the problem is, like, if you're looking at COVID or cardiovascular, then you miss all these things that impact Black communities in Canada because they don't capture that data at the disease level. And the problem is we see all these same disparities here, and like they're happening there, but the doctors, some patients don't get the right cancer therapy because they don't see race, but then that dismisses the actual, genetics and background of these Black and diaspora patients. Right. And so I've been doing a lot of stuff looking at that difference. And it's not that we're doing a great job at our disparities. At least we acknowledge them here, and generally, we generally are working to treat patients. But the reason I bring it up is, Canada is a much more international healthcare system. So their trainings come from all over. And so this is the whole philosophy is, we all see everyone as the same, but you can't then address disparities if you assume everyone is the same, because they don't come in with the same background or genetics or exposures. And so looping them all in the same means you completely miss what certain people have.
Yeah. No, thank you for sharing that. And when you think about the future that you're working towards, what gives you the most hope?
The one thing I'm hopeful for is that we have patients that see our resources and go to our lung cancer conference and are better able to articulate their needs in healthcare and advocate for what they should get, and then know they can get second opinions. And if we can prevent them from some of the herring stuff I dealt with, not that what happened to me is new or unique. It's just I happen to be a PhD who knows how to navigate. And I'm on Medicaid because I launched a nonprofit, so I have, we have no income. That's the only reason I'm on Medicaid. But regardless, if that happened to me, who knows how to advocate what is happening to everyone else? So my belief is, how can we put people in a position to advocate and know what they should expect and demand and require in their healthcare interactions? And if we can get people to do more of that, that will make me happy.
Yeah, that's so beautiful. Thank you so much for your time. I had a really wonderful time talking to you today. But how can people support you or stay connected to the work of SCHEQ?
Yep. So, we have our website, SCHEQ, SCHEQ.org. And you can also find us on LinkedIn, Instagram, and Facebook and STEMM are sort of the notation. And then I have a person, and I have my own personal LinkedIn, Eugene Manley. I can be followed there. And then we have a Blue Sky for SCHEQ. That's the only thing that's actually called SCHEQ is our Blue Sky. We don't do as much on our Blue Sky, but we do some stuff. But yeah, so website is SCHEQ. Our newsletter page and stuff. So yep.
Yeah, no, that's wonderful. And I keep hearing from people. I actually got to get on Blue Sky myself too. I got to make
a lot of
transition.
people. I mean, the medical people still stay on Twitter, but a lot of other people I know migrated off of Twitter because it's hard right now to do social justice, health equity, disparities when it's just not when there's so much vitriol coming towards people. So people just, there was a phase where, there was Blue Sky, there was the other, some kind of read platform, so more people are slowly using Blue Sky. That's a pro and a con, but it's like the old Twitter, you have X number of characters. So just get whatever you can say in those number of characters, which is kind of cool.
Wait, did you say Blue Sky has the same like Twitter limit?
Yeah, it has a limit. Like only so many characters. I think it's 200 or something. I forgot how many characters, but you have a hard character limit.
Okay, great. Well, thank you again for your time, and I wish you all the best and much success. I think the work that you're doing, as I said before, is really important, and I'd love to stay connected with you. And
sure, awesome. Thank you so much, and you're doing such a great job with your show, and you're really giving a voice to people that often aren't heard or seen, and just trying to amplify what they do. And I think that's just inspiring and powerful.
No, thank you so much for saying that, and I hope you have a good rest of your day.
Thank you. You as well. All right. Take care.
You too. Thank you for being here and tuning in to Voices That Propel Us, stories of justice, action, and community. Your presence in this movement matters. If today's conversation moved you, share it, talk about it, and keep the work going. Together, we're not just imagining change, we're making it. Until next time, stay bold, stay grounded, and stay in the fight.
I feel so mad and sad and bad, I say to myself, relax, lean back, it's a brand new day. And every time I feel so down that a frown is all